In this online lecture, I'm going to be talking about the musculoskeletal system and disorders associated with it. The musculoskeletal system is comprised of your bones, your muscles. It includes cartilage, tendons, ligaments, and other connective tissue. This system is going to provide you support, stability, and movement of your body. Today, I'm going to be talking about common musculoskeletal injuries and then some diseases that are associated with the musculoskeletal system. First off, some normal anatomy and physiology. I'm going to talk about normal bone remodeling. All bone cells participate in remodeling. In the remodeling sequence, what's going to occur is bone sections are going to be removed by what are called bone resorbing cells or bone breaking cells that are called osteoclasts, and then replaced with a new section laid down by bone forming or bone building cells called osteoblasts. Why is bone remodeling necessary? Well, it allows the skeleton to respond to all of the mechanical loading that you experience day to day. It helps maintain quality control, really allowing for repairing and preventing damage, and it allows the skeleton to release minerals and even growth factors that contribute to body processes. So that's osteoblast building cells and osteoclasts breaking cells. Osteocytes are just the mature bone cells that are found within bone. Let's look at these images for a moment. What we can see happening in the phase of normal bone remodeling, this being bone, here are your osteoclasts, those mature bone cells. We have osteoclasts that are breaking down or resorbing bone. And then we have these osteoblasts that are getting ready to build bone. And you can see that happening in this image here. So they're beginning to build bone, and then what we have at the end of it all is new bone that has replaced old bone. This is a micrograph just showing active bone remodeling. In this image E, this is the normal bone remodeling cycle that you would see in normal bone. And so we have that resorption by those osteoclasts again. They're digesting the bone, and then we have these pre-osteoblasts that are getting ready to form new bone, which you can see occurring here. And then when bone is neither being resorbed or formed, it is in its resting phase. In this final image, there are numerous signaling factors that are necessary for bone remodeling to occur. You can see a number of abbreviations shown here, and they're expanded upon here. And I'll be talking about the specific ones in a later slide that are relevant to bone remodeling, but are also relevant in the development of certain bone diseases. A bit more of normal anatomy to remind you of some important main features of bone. So if we look at a long bone here, we have the epiphyses or metaphyses on either end, and the diaphysis, the long shaft part of a long bone. We have the epiphyseal line here, which is a remnant of the growth plate. So the line would be present once the person has stopped growing. In the ends of long bone, we have spongy bone present, and red bone marrow would be found here, especially in children. And then the medullary cavity that is filled with yellow bone marrow. Remember that bone marrow is where our body produces blood cells. The outer covering of bone is called the periosteum. It's this sheath outside of the bone that supplies the bone with blood. There's nerves and even some cells that will help the bone grow and heal. And then we have the endosteum that lines the medullary cavity, or the central part of the bone. And I also wanted to mention that in the long bone here, we have compact bone present, much more dense bone. And then in the ends of long bones, we can see this spongy appearance. That's why it's called spongy bone. And what gives it the spongy appearance are what are called trabeculae, and so sometimes it's called trabecular bone, and it's like a lattice throughout here. Remember the difference between muscle, tendon, and ligament. In this example here, this is the brachialis muscle. This is the muscle itself, which is attached to a bone through a tendon. And so we can see the tendon very clearly here, and it crosses over a joint, which allows for that joint to move because the forearm, when this muscle contracts, will be pulled in an upward direction. So tendon then again connects muscle to bone, but what you can't see here because it's very fine is that there is a tendon present that's connecting this muscle to the bone. It's just not as obvious as it is here. And then a ligament is what is a connective tissue that connects bone to bone. So we have ligaments all throughout our body, very prevalent within joints. We have lots of them in our hands and lots of them in our feet, among other areas of the body. Joints where two bones come together to permit movement. And then bursa. Bursa are these fluid-filled sacs that are found in all different areas of our body. They're more prevalent in areas where a joint is present that has a lot of movement. So for example, our shoulder has various bursa that are present. And what a bursa will do is it'll be located between two structures to prevent friction between those two structures. So these guys will prevent friction in areas that they are found throughout the body. Now let's move on from normal anatomy and look at abnormal, starting with fractures. A fracture is a break in the continuity of bone. And a break or a fracture is going to occur when force is applied that exceeds the strength of the bone, whether it's the tensile or compressive strength of the bone. A fracture is no different than a break. If somebody says they have a broken bone, that is a fracture, but there are different types that exist. In this image, you can see a variety of different types of bone fractures, and the ones that are starred are the ones that I will be discussing in more detail. The first one is an open fracture, also known as a compound fracture, so that's shown here. An open fracture occurs when, as the name suggests, the skin is broken over the fracture, which you can see here. So these ones look really nasty when you see them. The soft tissues are naturally going to be damaged in the area because the bone has broken through soft tissues. And the internal cavity of the bone, which we know contains bone marrow, is now exposed to the external environment, and that puts a person at risk of developing an infection. There's an infection that will be talked about later in this topic of musculoskeletal disorders called osteomyelitis, and that's inflammation of bone or bone marrow, usually due to some sort of infection. So that is one method by which osteomyelitis can occur. And so a closed fracture then, also known as a simple fracture, it's not defined explicitly here, but that should be pretty obvious. It's a fracture that does not break through the soft tissues. It does not break through the skin. So it's typically less complicated. Pathologic fracture, shown here as D. Pathologic fractures are caused by some sort of pathology relating to disease. So for example, let's say you have a female that has osteoporosis, which we'll also talk about in this topic. It just means that their bone density or their integrity of their bone is poor. And if the bone's integrity is poor, then they are prone to developing or having a fracture from something like a simple fall. Another example would be if somebody has cancer that either originated in bone or spread to bone can affect the integrity of the bone, and it can cause a fracture to occur. So a pathologic fracture is a fracture then that results because of some sort of pathology, the examples being osteoporosis or maybe cancer in bone. And so bone breaks under a situation where it normally shouldn't. So if you have somebody that falls a short distance and breaks their hip, That should be a flag to the healthcare provider that, well, they only fell a short distance. Why did their hip break? The hip is a strong bone. And when I say hip, I'm really referring to the head of the femur here, or the neck of the femur. If this breaks, that's kind of unusual. So it should be a red flag to the healthcare provider to investigate, is there something wrong with the integrity of that person's bone compared to normal that predisposed them to a break? Comminuted fracture. A comminuted fracture is when there is a fracture with two or more pieces or segments of bone. So sometimes it's called a segmented fracture because the bone's been segmented into multiple pieces. You can see that here. This can be more problematic for healing, especially if there is any displacement of that piece of bone. And so we'll talk about on an upcoming slide, when there is a fracture, part of the healing process involves a callus formation. And so when there are multiple pieces of bone present, the callus formation, part of the normal healing process, is more challenging. For the most part, if somebody has a comminuted fracture, they would have to have experienced moderate to severe force for this type of fracture to occur. So let's say somebody is in a severe motor vehicle accident, for example. An impacted fracture occurs when there's an extensive force that breaks a bone and then causes the broken ends of the bone, so here, this bone here, and the femoral head here, there's the break here, and then the force is strong enough that it causes those ends to jam together or impact, and one of the broken bones almost wedges into the other. A green stick fracture, these are one of the coolest in terms of where the name comes from. A green stick fracture is a break in only one cortex of bone, so it breaks through, say, the outer surface of bone that's disrupted, but the inner surface is intact. So why is it called a green stick fracture? When kids are young, when people are young, their bones are more pliable. And so green stick fractures can occur more likely in kids than, say, a grown adult. And I want you to think about this. Let's say you're out in the winter and you find a stick or a twig on the ground from a tree. If you were to take that twig, that brown twig, and bend it in half, it would crack. It would break right through. But let's say it's the springtime and you break a branch off the tree that is just growing and it's still got that green covering on it. It's still soft, it's still developing. And you tried to crack that in half. What would happen is, and I want you to try to picture this, as you're trying to break it, the green part of that branch is going to start to fray apart. So it's difficult to crack it in half, but that outer covering, really the green part of the stick, hence the name green stick fracture, is like the outer part of bone, and that's the part that breaks, that outer part, rather than all the way through. And so if you have, let's say, a 6-year-old that's playing on a playground and she falls off and she breaks her arm, there is a chance that she has sustained a green stick fracture. An avulsion fracture. Avulsion fractures involve a fragment of bone that is connected to a ligament or a tendon, breaks off from the main bone. So I want you to picture it like this. You have let's go back to, actually I'll go to this image here. This would be unlikely to happen in this area, but just to give you an example of what an avulsion fracture would look like, this tendon is very strongly connected to the bone. If the tendon pulls off the bone, it can sometimes take some of the bone with it. That is called an avulsion fracture. The final comparison that I want to make is the difference between a complete versus an incomplete fracture. And the name itself really tells you what the difference is. Complete would be where the bone is broken all the way through, whereas incomplete, the bone is damaged but still in one piece. And so if we go to this next image here, we can see that an incomplete fracture is it didn't go all the way through, whereas a complete fracture, if you look closely, you can see that it went all the way through. And then here's another example of an open fracture. So let's talk about what happens when a bone is broken or a bone fractures. After the break occurs, damage is going to be evident to the tissues that surround the area, and that will include the periosteum. Remember, that's that dense layer of very vascular connective tissue that sort of envelopes the bone. Not the surfaces of the joints, but the rest of the bone. Now, bleeding will occur, and this is because of damage to the periosteum, which again is densely vascularized. And the bleeding can occur because of the break through the periosteum, but also if it's a big enough break to the bone medullary area, then that can bleed as well. So just to rephrase that, bleeding can occur from both the cortex or the outer part of the bone as well as the medullary area. Next up, a clot called a hematoma will form. It'll form into this fibrous network that really works to prevent further blood loss. Now, some tissue death does occur, and this is going to lead to a very strong inflammatory response. And the goal will be to clean up the area. And so we're going to have recruitment of osteoblasts that are going to begin forming what's called a procallus. Now, a procallus is a fibrocartilage tissue. And this acts as sort of like a temporary brace. So you get this collagen that's deposited that helps keep the bone together, but it's temporary. This procallus will oftentimes disappear. It'll be broken down. In some cases, the procallus itself can calcify and turn into bone. Next up, the callus itself, so we go from procallus to callus, the callus itself is going to begin to form. And so the callus is this bony healing type of tissue that forms around the ends of the broken bone, and new bone will be generated and old bone will be destroyed. So we've kind of cleaned out the area and laid new bone down. And finally, remodeling occurs. And this is where unnecessary callus is going to be resorbed and trabeculae are going to be formed along lines of stress. So we've taken a bone that is broken and we've repaired it so that it should be able to withstand the normal stressors that a bone is expected to withstand. And bone is unique, just like the liver, because bone and liver among all body tissues are the only tissues or only organs we can say that have the ability to break and then heal with normal tissue. Other organs and tissues in the body, when they are broken or injured, they heal, but not without scar tissue. On this slide, I'm going to be discussing some of the potential consequences of injury that can affect joints, tendons, ligaments, and muscles. Keep in mind that the injuries that I'm going to be talking about can occur alongside a fracture, but can also occur without a fracture. The first definition or term is dislocation. Dislocation is a total and temporary loss of contact between articular cartilage. So this is where, and this is showing you the humeral head here, it has completely dislocated from where it forms a joint with the glenoid cavity of the scapula. And it can be relocated, that's why it is considered temporary. But in the process of dislocation, it can pull on cartilage and tendons and ligaments and muscles in the area, causing further injury to structures. Next up is subluxation. A medical subluxation is partial loss of contact between two articular surfaces of bone. So dislocation is total. Subluxation is just beneath that in terms of severity. It's partial loss of contact. Not overly clear to see here, but we've lost partial contact here with the glenoid cavity. Dislocation and subluxation are very common to the shoulder. And this is a shoulder shown here, but it can also commonly occur in the elbow, the wrist, the hip, and the knee, or really any joint that permits enough movement to allow the joint to be separated. Next up is the difference between a strain and a sprain. A strain is a tear or injury to a tendon or a muscle. So think of that maybe T in there referring to tendon if it helps you know the difference. So we get this stretching or this tearing of a muscle or tendon, and because of better vascular supply, a strain will heal better than our next definition, which is a sprain. And a sprain involves a tear or injury to a ligament. I hear these terms used interchangeably all the time, but as you can see, they refer to an injury to different structures. And due to poor vascular supply with ligaments, they don't heal as well. And in some cases, somebody that experiences a sprain will not ever experience full recovery and full repair. And our ligaments play a really big role in proprioception, which is knowing where our body is in space. So, for example, if you are walking, every step that you take, your proprioception, which is feedback that is provided to your central nervous system, that feedback will tell you where that foot is in space and how you're supposed to move around, so that if you do step on something on uneven terrain, you're less likely to roll that ankle over because of appropriate feedback that allows you to correct for different positions. But if somebody sprains their ankle, especially if it's a bad sprain and they injure the ligaments and lose some of that proprioception, then if they step on an uneven terrain and then their ankle starts to roll over because they've lost some of that feedback, they may not be able to correct that position and then continue to roll their foot over and further sprain their ankle. So that's where, if you know someone that, or even yourself, if you've sprained your ankle in the past and you've sprained it many times since then, the reason for that is because the ligaments don't heal as well and you lose some of that valuable proprioception. Bursitis. I introduced or reminded you of what a bursa is on an earlier slide. And so bursitis would be inflammation-itis of bursa. Remember that bursa are those fluid-filled sacs, and they can become inflamed in different areas of the body, very common in the shoulder and the hip, and cause significant pain in that area when they're inflamed. Next up is a condition called rhabdomyolysis. The definition of rhabdomyolysis is the rapid breakdown of muscle. So muscle is damaged severely. It releases one of its proteins, that's a pigment called myoglobin, into the blood. And when myoglobin ends up in the blood, it does indicate that there's been muscle damage, and enough myoglobin can be in the blood that it ends up being filtered through the kidney into the urine. And that's what myoglobinuria is the presence of myoglobin in the urine. And again, that would be indicative of muscle damage. So for example, you could have somebody that has a bad fall and they break their arm. And the arm is broken enough, bad enough, that the muscles in the area are damaged severely. And this damage can release the myoglobin from the muscle into the blood, and then it ends up in the urine. And because myoglobin is a protein, and we know proteins should not end up in the urine, and if they do, it can indicate that the kidney has been overwhelmed and maybe even damaged. And so an important consideration of somebody that has myoglobin in their urine is are the kidneys okay? Were they able to tolerate what they just filtered? Finally, tendinopathy. Tendinopathy refers to some sort of disease or condition or state that is abnormal of a tendon. And we can have two different types, tendinitis and tendinosis, and they're oftentimes used interchangeably. When there is the thought of inflammation to be present, although this is a constant debate whether or not tendons can really be inflamed, but when there's inflammation thought to be present because somebody has had a recent injury, then tendinitis would be the diagnosis. Whereas tendinosis is really more long-standing condition where there's been some degradation of the collagen fibers that make up the integrity and structure of the tendon. Next up is osteoporosis. So we're moving on to a totally different topic now. You should make sure that you are aware that osteoporosis is the most common bone disease in humans, a very common bone disorder. Everybody in their life will know somebody, whether they know it or not, that has osteoporosis. Osteoporosis means porous bone. So if we look at this term here, osteo means bone, then we have osis is condition, and then the pore part is referring to porous. So porous bone, and it's generally described as this decrease in bone mineral density. So progressive loss of bone density. In osteoporosis, what we have is this situation where old bone is being resorbed faster than new bone is being made. And so we have this discrepancy in the ratio of bone destruction and bone formation. So it leads to this overall loss in bone density where bone becomes thinner and, as already mentioned, more porous. Now, histologically, if you were to look at bone that is affected by osteoporosis under a microscope, the histology, it looks normal, but it lacks structural integrity. One of the issues with osteoporosis is that it can progress silently for decades. And in some cases, it's not known that a person or suspected that a person has osteoporosis until they have a fall. And then they suffer a fracture, and they fracture an area of their body such as their wrist or hip that are maybe not common to fracture from a short distance fall. In the past, and even some would say now, osteoporosis was considered a consequence of aging. However, some elderly people remain strong and maintain relatively dense bones. Potential causes include a reduction in estrogen and a reduction in testosterone, but this is a big one because women are more affected than men. Reduction in activity level. The reason for this is because every time we do any form of weight-bearing activity, we build bone. And so if we're not doing weight-bearing activity, and we're seeing a lot more people that have lifelong sedentary jobs, if you're not doing weight-bearing activity, whether it's at your job or outside of it, you're not building bone as well. And so if you have somebody that has, maybe as they get older, they've had some sort of injury for whatever reason, or they have maybe cancer or something that's caused them to be more either bedridden or more sedentary, especially if they're female, they have an increased chance of developing osteoporosis. And then inadequate levels of calcium, vitamin D, and magnesium are also thought to contribute to the development of osteoporosis and certainly worsen it if somebody already has osteoporosis. So in particular, vitamin D and magnesium, they are essential for bone synthesis. And so if they're not available, then the course of osteoporosis can intensify. If we look at this image here, you can see a normal vertebrae. And then here we have one that has suffered from osteoporosis, but also suffered from a compression fracture. And a compression fracture is where you can see that obvious loss in vertebral height. And a compression fracture, you might recall from earlier in today's lecture, is a pathological fracture. And what this can do over time is cause changes in the person's posture as the vertebrae that make up the spine are compressed. So we have this accentuated kyphosis, remembering that normally the cervical spine and the lumbar spine demonstrate a lordosis, and the thoracic spine demonstrates a kyphosis. This is an accentuated kyphosis in somebody with osteoporosis, and you can even see that now their neck has also lost its normal lordosis. So if you're slouching right now as you watch this, sit up and improve that posture. Your neck as well will thank you. Continuing on with osteoporosis, I already told you that it can lead to these pathologic fractures, those compression fractures that I showed you on the last slide. What you do need to make sure you make note of here is that the most common location for these pathologic fractures to occur is in the vertebrae, as already discussed. And the other important note I'd like you to make note of is that it's in the thoracic vertebrae. And I talked about that already. We have these compression fractures of the vertebrae, most commonly affecting the thoracic spine, leading to this accentuated kyphosis. So please make sure you know that. Now, this progressive loss in bone is going to be more obvious in trabecular bone, that spongy bone that already has that spongy looking appearance compared to compact bone. We know also that there's going to be this imbalance between osteoblast and osteoclast activity. We want them to be balanced. We want to break down the same amount of bone as we are replacing. But what happens with osteoporosis is we have more breaking of bone than we do building of bone. Somebody's bone density can be measured to determine what their current status is of bone density. And what we're looking at here is the quantity of bone that is present rather than the quality of it. And so with somebody that has osteoporosis or somebody who's leaning towards being osteoporotic would have a lower bone density, so lower quantity overall of bone. It's less dense. When I mentioned earlier that it's more obvious in trabecular or spongy bone, we can see that here. So here's compact bone, and here's spongy bone. You can see that as you have progressive bone loss, it's going to be more obvious in the trabecular spongy bone because there's really less of it to begin with. It's already sort of porous in its appearance, but it has a unique design that allows us to withstand normal stressors, but it thins out, as you can see. Now, what I want you to make note of is that we have this term osteopenia here, just before osteoporosis. So this would be a continuum here. So if somebody with normal bone, they can become osteopenic, then they can become osteoporotic, and then they could end up with severe osteoporosis over time if it's not managed appropriately. So what's the difference then between osteopenia and osteoporosis? If somebody gets the diagnosis osteopenia, this is the best time to know that your bone density is low. Once you're diagnosed with osteoporosis, you can't go back. All you can really do is help prevent further loss, but you can't go back no matter how hard you work, or at least not yet anyways. But with osteopenia, with this diagnosis, it means there is evidence that there is less dense bone than is considered normal or ideal. Penia, think of it meaning less or small. We have less bone than normal. And with this diagnosis, you can actually prevent getting to the state of osteoporosis if measures are taken to improve bone density, which will likely include weight-bearing exercise. It will likely include nutritional changes or dietary changes, as well as medications and supplements. Still on the topic of osteoporosis, I'm going to talk about the OPG Rankel rank system. This is a slide that I do want you to star because it's going to be important for testing purposes, and it's a little bit trickier than some of our other slides and the rest of the lectures. So definitely pay attention to this slide. Osteoporosis develops, as we spoke about already, when the remodeling cycle between bone resorption done by osteoclasts and bone formation done by osteoblasts, when that normal cycle is disrupted. And so this leads to an imbalance in this, which should be a coupling process between clasts and blasts. So looking at this image, I know it's a very busy diagram, but I'll point out exactly what it is that you need to know. This here is an osteoblast, a bone building cell. This osteoblast produces two important substances. One is called rankle, and that's a cytokine, and the other is called OPG, and this is a glycoprotein. Now, osteoclasts, and here we have a mature osteoclast. This is an osteoclast precursor that will mature into a mature osteoclast. Osteoclasts, the bone resorbing or bone breaking cells, they possess a receptor here called rank. So osteoclasts contain a receptor called rank. This rank receptor is designed for rankle, the cytokine that's produced by the osteoblast. So the osteoblast here will produce rankle. Rankle will bind with the rank receptor on osteoclasts, and this will then stimulate the osteoclast. So rank receptors must be stimulated to activate the osteoclast. Now, stimulation of this osteoclast by rankle binding to rank will stimulate the osteoclast to do its job, which is bone resorption. So you can see that the osteoblasts and osteoclasts are really working together, even though their specific job is different. Now, one thing that needs to be considered here is controlling the amount of rankle that is binding to rank, because we don't want excessive stimulation of the osteoclast. So the osteoblast also produces a substance, a glycoprotein called OPG. OPG acts as a decoy to prevent excessive bone resorption. So what does that mean? Well, OPG is also going to bind to this receptor, really blocking its activity, preventing or blocking, I should say, the receptor site so that rankle cannot bind to it. And by blocking it with this decoy called OPG, then we can control the amount of bone resorption occurring by osteoclasts. So again, osteoblasts produce rankle, which will bind to the rank receptor on the osteoclasts, stimulating it to resorb or break down bone. But in order to not break down too much bone, OPG, also produced by osteoblasts, OPG is going to act as a decoy and really block this receptor so that the rankle cannot bind to it to stimulate osteoclast activity. So this prevents too much bone resorption. So the reason you need to be aware of these two substances is because there are a variety of different factors that can change how rankle is expressed and how OPG is produced. And you can see many of those factors listed here, but what I want to bring your attention to is this here, which you can, if you want, just cross off and put estrogen if it simplifies it. You can see in both cases, estrogen is going to affect rankle expression and OPG production. Estrogen will have a different effect on rankle versus OPG. Starting with rankle. Rankle production is going to be decreased by estrogen. Okay, so that's shown here, rankle expression decreased by estrogen. Remember that rankle produced by your osteoblasts, your bone building cells, rankle is going to bind with osteoclasts in order to stimulate the osteoclast activity, which is breaking down bone. So it's, remember, this controlled process and this balance between building and breaking. So they're really working together. Now, estrogen is going to be, let's talk about females, higher in females before menopause. And so estrogen that is present in the body prior to menopause is going to reduce the amount of rankle that's produced, meaning that we're going to be breaking down overall less bone. And this helps with that balance of bone building versus breaking down. So to summarize that, listening to my words, prior to menopause, when estrogen levels are higher, there's going to be less production of rankle by osteoblasts, which will mean less stimulation of the osteoclasts, which break down bone. OPG production is affected by estrogen differently. With OPG, its production is actually increased by estrogen. And we can see that here, increased by estrogen. OPG, remember, is that really decoy that's produced as well by the osteoblasts that will go and block this site, really having the same effect, meaning that prior to menopause, when estrogen levels are high, more OPG is going to be produced, meaning more decoys that are really pretending to be the rankle, blocking the receptor site on the osteoclast, the bone resorbing cell, in order to reduce the amount of stimulation or activity by that osteoclast. Again, working to not have too much osteoclast activity. We don't want to break down too much bone. But the problem after menopause is that there's less estrogen that's produced. And if there's less estrogen that's produced, it means there's going to be more rankle expression. If there's less estrogen produced, it means there's going to be less OPG production. And so in this case, we're going to see more stimulation of these osteoclasts. Just to remind you again, the reason for that is because we're producing more rankle, which we know stimulates osteoclasts to begin bone resorbing. We know there's going to be less OPG, which prevents or really blocks that site for rankle. And if there's less of this, there's less blocking and therefore more osteoclast activation. And so with this increase in osteoclast activation or stimulation, more bone is going to be broken down than it is built. We've sort of lost the control mechanism. And so one of the things that can be done to help slow the progression of osteoporosis is using drugs that are going to block those rank receptors, blocking them so that less rankle can bind to them. The other option could be to give OPG, which stands for osteoprotogerin. If you give somebody OPG, then you have more decoys available to block those active sites found on the osteoclasts. And if they're blocked, we can prevent their activation. So that's the most detailed and trickiest slide, but definitely a good one for you to understand. So let's have a look at the progression over life of osteopenia and osteoporosis. In this first graph, you can see age shown on the x-axis, and on the y-axis, it's showing bone density. And what we can see from age 0 to 20 is this incline in bone density, which makes sense. But then once you're around the age of 20, then it starts to peak. And so from age 20 up until around age 50, we see bone mass is remaining relatively stable. Now, this can fluctuate depending on the person and depending on their body weight overall. A heavier person is going to be able to build more bone because carrying their heavier body around actually builds bone density, or somebody who exercises is going to build more bone. So there's a lot of factors that can slightly affect this. But once you get to around the age of 40, what we can see is this drop-off that starts to occur, especially if the person is not making healthy lifestyle choices and not staying active. We get this drop-off. And the ideal situation is, yes, somebody will drop off, but they still remain in this safe zone where they have normal bone mineral density. Where it becomes problematic is if we drop into osteopenia and then osteoporosis. So we can see then that over time, as we age, there is a drop in bone mineral density. A normal drop is the ideal situation, and more than that becomes problematic. Looking at this graph here, we have bone mineral density again on the y-axis and age on the x-axis. And we can see three different areas: osteoporosis, osteopenia, and this would be normal bone mineral density. And the point of this slide is that the higher off you start, so here's a starting point, somebody that's starting osteopenic. That's unlikely that they would be that way at age 20. And then we have here and we have here as the starting point for bone mineral density. The higher you start with your bone mineral density, the better off you are. So how do you start off higher? It would be things such as exercise in youth, exercise continuing as an adult. The problem is sedentary lifestyles, even for young children who, instead of playing outside, are sitting playing video games, are putting themselves at risk in their future. Starting off then with a higher bone mineral density, just the natural drop that occurs with age puts somebody in a better situation than if they started off lower. You can see that drop progressing even into osteoporosis, and then this one being a major problem. So sedentary lifestyles, unhealthy lifestyles at a young age are putting somebody at risk for the development of osteoporosis, especially as a female because of the hormonal changes with estrogen described earlier. Osteoporosis, men versus women. So I've already told you women are predisposed and hormones are a good reason for that, one of the reasons for that. But if you look at the trabecular bone, the spongy bone in women that have osteoporosis versus men, there is a difference in how the bone appears. You can see with men it's thinner. With women it's perforated. So you actually have breakage of those trabecular branches, more so in women than men. And then in this image here, showing you bone changes in men versus women, looking at compact bone, you can see there's much more of a concern in women with what's reabsorbed compared to men. So overall net bone loss in women is greater than men. Some complications that can occur with osteoporosis include this accentuated kyphosis, as spoken about earlier. And a part of that, some people think it's just bad posture over time, but it's because of compression fractures of the thoracic spine in particular that can cause this posture. So remember, that's a pathological fracture. Another example of a pathological fracture that can occur is within the hip. So somebody that has osteoporosis could have a really minor fall and still break a bone that otherwise should not, under normal circumstances, such as a short fall, break. But in those with osteoporosis, the bone is weaker. Now on to a new topic, muscular dystrophies. They are a group of inherited disorders, so they have a genetic component that causes progressive, meaning it gets worse over time, skeletal muscle fiber loss and degeneration. So these are voluntary muscles. So you get this symmetric weakness on both sides of the body and wasting of your skeletal muscle groups. Muscular dystrophies are the most prevalent of muscle diseases in childhood, with increasing disability and deformity, and severity can depend on the type of dystrophy. But looking at muscular dystrophies as sort of an umbrella term, we can say that it is the most common genetic skeletal muscle alteration. Now, of the different types of musculoskeletal dystrophies, the most common is Duchenne muscular dystrophy. This is an X-linked recessive inheritance. Now, when you look at rules of X-linked or sex-linked recessive inheritance, females are more likely to be carriers while males are more likely to be affected, and I'm going to explain that now. We know that the female chromosomes, that 23rd pair of sex chromosomes, are going to be XX and males are going to be XY. If we look at a situation where here's a male and they have a healthy X chromosome, and here's a female. She has one healthy X chromosome, and then she has the Duchenne muscular dystrophy defect. She is a carrier. The reason she is a carrier, so the husband is healthy, the male is healthy, the reason she is a carrier is because she carries it on one X chromosome, but because she has another X chromosome, that dominates. So that's protective. Because remember, with recessive, you need to see it when it comes to having two X chromosomes. You need to see it on both for it to be expressed. So the healthy one will dominate, but she's a carrier. And why that's a concern is because she could pass that on. So let's say this male and this female have a female child. Let's look at some instances. They could have a female that is a carrier just like the mom is, or they could have a non-carrier where both genes, both X chromosomes, I should say, are healthy, and there won't be any passing on. So these are the two situations. With males, though, it becomes tricky. Males have an X chromosome, we know, but then they have this smaller Y chromosome that carries different information. So they don't have a protective second X chromosome if one of them is affected. So in this case, they have a child that's a male. There is a chance that the child will inherit that affected gene on their X chromosome. Because they don't have the Y to protect, this is going to dominate and this male will be affected. The other circumstance is that the child could not inherit the affected gene, as you can see here. So that's why females are more often carriers, while males are affected when it comes to sex-linked or X-linked recessive inheritance. Now on the next slide, I'm going to be talking a bit more about Duchenne muscular dystrophy, one of the different types, most common, of muscular dystrophies. Thinking back to normal anatomy, there is a protein that's present normally in muscle cells that's called dystrophin. So this is important for you to know. Dystrophin, we're talking normal, maintains the structural integrity of the cytoskeleton of skeletal muscle fibers. Those that have Duchenne muscular dystrophy due to that defect in the X chromosome, they don't produce enough or maybe none at all of this dystrophin. And so if you have a case of complete lack of dystrophin like you would see in severe Duchenne muscular dystrophy, it means that you have this poor anchorage of fibers. So here's dystrophin. If we're lacking this or we don't have enough, the muscle fibers can be torn apart under repeated stress, even just under a normal contraction that we don't really think anything about. If you don't have Duchenne muscular dystrophy, you don't even think twice about taking in a deep breath or walking over from one table to another. One of the negative effects that can be seen when you have these tearing of fibers with Duchenne muscular dystrophy is that calcium, free calcium, now has the ability to enter the muscle cells. And calcium, as you would have learned in earlier versions of this course, can be very damaging to a cell. Free calcium is toxic to the cell, and this can lead to death and necrosis. Clinical manifestations, so the signs, symptoms, the evidence that a disease exists, are usually identified around the age of 3 years. And this is where parents will start to notice that their child has slow motor development, and they've noticed that there's muscle weakness and wasting that seems to be progressing. There might be delays in even at a young age, before the age of 3, in sitting, in standing, and walking. The child could be clumsy. They could fall and have difficulty with things such as climbing stairs. Unfortunately, cardiac muscle can also be affected with this condition, and respiratory muscles, the muscles that are used to help open up your thoracic cavity to allow you to take air in, is an action we don't think much about. But this can be lost in those with Duchenne's muscular dystrophy. And if you lose the ability to breathe, that's going to be a great concern. Muscle cells over time deteriorate, and they end up being replaced by connective tissue and fat, which are not going to do them any good when it comes to what we really need muscles for. The life expectancy of somebody with Duchenne muscular dystrophy, and this can obviously be different depending on the severity, but is usually the mid-20s. Steroid use will oftentimes be a part of the person's therapy, and the use of ventilation. These can help support the person, but increase their life expectancy. In this image here, this is a patient that has late-stage Duchenne muscular dystrophy. You can see severe muscle loss. This here is a transverse section of the gastrocnemius muscle, so the calf, from a normal boy and then one with Duchenne muscular dystrophy. And one of the things that is evident here is that the muscle fiber has been replaced by fat and connective tissue, as mentioned earlier. And you can see a lot of deformity here. And this is because people with Duchenne's muscular dystrophy are predisposed to contractures while also being predisposed to wasting of muscles. And all of the changes that are occurring on both of those accounts can lead to deformity of the skeleton. Now on to the topic of dysplasia of the hip. We're going to look at developmental dysplasia of the hip. It is usually congenital, meaning that a child is born with it or it's present at birth, but it can occur anytime during the newborn or infant period. It involves abnormality of the femoral head, the acetabulum, or both. So let's look at this normal image here. Here's the femur. This is the proximal end of the femur. This is the femoral head, which forms a joint with the acetabulum of the pelvis. And so that's the hip joint. Those with developmental dysplasia of the hip can have either an abnormality with the head, the femoral head, with the acetabulum, or with both. And this abnormality can cause the hip to not have its normal range of motion and stability. Risk factors include being female, oligohydramnios, which is a deficient volume or low volume of amniotic fluid, and less amniotic fluid, so that fluid that the baby would bathe in, limits fetal movement, and less movement can predispose the baby to this condition where either the femoral head or the acetabulum or both do not develop properly. Positive family history is another risk factor, as well as breech presentation. So that's where the baby is presenting with their, in some cases, feet first. Now, the problems won't be really evident as far as the parents are concerned until the child learns to walk. And this can lead to dislocations of the hip in more severe cases. But there are tests that can be done really in the early stages with a newborn to determine if there is possible developmental dysplasia of the hip. And these tests that we'll look at are called Barlow test and Ortolani test. Before I talk about these tests, I want to mention that developmental dysplasia of the hip can be described as being subluxated, dislocated, or it can be described as acetabular dysplasia. I'm going to talk just a little bit about these. With subluxated, it means that there's only partial contact between the femoral head and the acetabulum. So in this normal circumstance, what we have is a nice, deeply seated femoral head into the acetabulum. But with subluxated varieties of developmental hip dysplasia, it's just not seated very well, that is, the femoral head within the acetabulum. And because of that, it has the ability to be fairly easily dislocated because it's just not sitting in there well. Now with dislocated, you can see that there is no contact. There becomes no contact between the femoral head and the acetabulum. With acetabular dysplasia, the femoral head, and I don't have an image here, but the femoral head is located okay. Its location is okay. But the problem is the acetabulum. The acetabulum is too shallow. So what we would see here then would be, instead of a nice deep acetabulum for that femoral head to fit into, okay, so nice deep acetabulum, it's more shallow. And if it's more shallow, then that femoral head that sits in there is not going to be able to stay in there, no matter how well that femoral head is designed. I'd like you to make note that there is usually some degree of acetabular dysplasia found with the subluxated and the dislocated varieties. Now let's look at these tests. If you are interested in this, I would suggest that you go online and watch a video for your own interest on the actual mechanism, because it's a little bit hard to describe from pictures. But all I want you to be aware of is that with the Barlow test, which is done first before the Ortolani test, with the Barlow test, you're going to have an examiner that grabs the inner thigh near the hip of the baby, and they're just going to apply a little bit of posterior and lateral pressure, sort of attempting really to dislocate the femoral head from the acetabulum. Under normal circumstances, it won't dislocate, but in a child with developmental dysplasia of the hip, it very well might dislocate. And so if the hip is dislocatable, you're going to hear this distinct clunk as the femoral head pops out of the joint. And so that description there, where the examiner is able to dislocate the hip, is a dislocatable form of developmental dysplasia of the hip. Now, the Ortolani test, which can be done right after the Barlow test in a case where the hip has popped out of place, will relocate that hip. So it's sort of the somewhat opposite movement. You can see the hand is now placed more posteriorly, and the examiner attempts then to relocate that already dislocated femoral head back into the acetabulum, and then you would hear this or really palpate or feel this clunk as the head slides back into place. So that was really describing a dislocatable hip, but you can have circumstances where the contact between the femoral head and the acetabulum is so poor that it just cannot stay in place. And so the hip is already dislocated. And so the examiner can try to relocate the hip with Ortolani's test. Now, it is important to know with those tests that they may only be doable for the first few weeks of life, and that's a good time to do those tests as part of just a normal infant or newborn examination. They become less reliable as the child gets older. But if it is identified at a young age, the patient can be put into what's called a Pavlik harness that will brace the hip in a position of abduction and flexion. And this allows for some remodeling to occur depending on the specific type of dysplasia. It can allow the acetabulum to remodel itself. And if this is done in children that are less than 6 months of age, then it has a 98% success rate. But if it's done later on, then things change a little bit. The process changes, the outcomes change, and it may even need to be surgical. And if you wait and don't do anything at all when something should be done, it can predispose to further degeneration where the patient is more likely to have osteoarthritis at a young age. This is just showing you some progression of the condition. You can see how shallow the acetabulum is. In these cases, you're not going to have good contact at all. I had mentioned earlier that one of the risk factors for developmental dysplasia of the hip is a low amount of amniotic fluid that limits the amount of movement that the baby can have. And this movement that the baby would normally have with normal amount of amniotic fluid helps the hips develop normally. And so I'd also mentioned to you that a lot of times this is present at birth, but it can occur a little bit later in the infant's life. And why does that occur? Well, one example could just be the position that the baby is in while they're young. Maybe they are spending too much time wrapped in some sort of baby sling. Maybe they spend a lot of time in a poor position in an infant carrier that the parents will wear. When I said wrapped, I mean sometimes babies will be wrapped up tightly before they go to bed, which limits movement. And when we limit normal movement or we put a baby in an awkward position, then it can change the development of the hip. And so this position here sort of is an M shape as part of the rehab. And that's actually encouraged in terms of the position that a baby is in when they're being carried in a carrier by the parents. You've probably seen parents with these carriers on their back or their front that a baby is in. And what you don't want to see is the hips, the legs being straight down, especially if they're going to be carried in these carriers for long periods. You want them to be supported in this fashion. That's all for today's lecture. Thanks for your time.